Hey, Mike Gibson, Bill Fearon, joining you live from AHA 2025. We're talking about one of the trials that I like the name of, the CAVIAR study. Bill, talk to us a little bit about what you did and what you found.
Great. Well, thanks for having me, Mike. Yeah, the CAVIAR trial is an NIH funded study that is looking at cardiac transplant recipients, patients who've undergone heart transplantation, and investigating the accelerated atherosclerosis that these patients can suffer from, otherwise known as cardiac allograft vasculopathy, or CAV. That's the first part of the CAVIAR acronym. And CAV is one of the leading causes of morbidity and mortality in transplant patients. And it's still poorly controlled in many cases. And what we were interested in looking at is whether we could decrease its incidence. And it's a multifactorial process related to certainly the immune response to the transplant, as well as infectious issues, and then also just typical risk factors, in particular dyslipidemia. And in many cases, transplant patients can't tolerate statins, or the dosage isn't at adequate levels to control their LDL cholesterol. And so that raises the question of, well, if we could improve that, would that decrease the incidence of CAV and improve their outcomes? And one class of medications that hasn't been well studied in transplant patients are PCSK9 inhibitors. And that's where the IAR, inhibition with AliRocumab, comes in. So AliRocumab is one of the PCSK9 inhibitors that hasn't been studied in transplant patients. So the goal of our study was to see whether adding a PCSK9 inhibitor, AliRocumab, on top of statin therapy would improve outcomes with regard to the development of cardiac allograft vasculopathy. And the way we diagnose this entity is primarily by doing intravascular ultrasound. And it involves typically doing it early after transplantation in order to get a baseline assessment, because some patients do receive transplanted hearts that have donor-related disease, and then repeating it at 1 year. And it turns out that the change in plaque during that first year is a reflection of development of CAV, and also has prognostic impact in the long term. Now, CAV is also affects the microcirculation as well as the large vessels, and we've been very interested in that and done a lot of work looking at microvascular function, CMD, with IMR and CFR, and have shown that that can be prognostically important too. So the way we set up this study, it was a double-blind, randomized, placebo-controlled trial. We enrolled 114 patients, and they were randomized to either AliRocumab or matching placebo. And we did, before they started the treatment, we did a baseline invasive evaluation, including a coronary angiogram, intravascular imaging with NIRS IVUS. We were very interested also in looking at the lipid content and seeing
Mm-hmm.
if there was a difference there. And then we did coronary physiology as well, measuring fractional flow reserve, coronary flow reserve, index of microcirculatory resistance, and finally, endothelial function with acetylcholine. And so we did
Wow.
all that at baseline, as well as, of course, laboratory studies for biomarkers. And then they were randomized, and then they were treated for a year. And then they came back, and we did a follow-up evaluation about 1 year after transplant and after they're starting the treatment.
You know what I always tell fellows? They're like, well, how do I get to do a big trial? Or I said, don't do a big trial. Do a very, very beautiful, elegant cath lab study with all the tools that we have. And you're such a genius at that. So I'm excited to see what you found. So what did you see?
Yeah, thanks, Mike. So the first thing we found is that alirocumab is safe. We didn't have any significant adverse effects in either the arm, the alirocumab or the placebo arm. And we also found it was quite effective at reducing LDL. I think both of those you kind of could predict, but it was
Sure.
good to document because I think there are physicians out there who feel reluctant to use a new medicine until we have some good data like this to show that it's safety. And no one really knows for sure how it's going to interact with immunosuppressants and other treatments that those patients get. So the average LDL was lower than we anticipated. So both groups, I should say, were treated aggressively with rosuvastatin, which is also a little bit different because many centers will use pravastatin or lower doses of other statins because they're concerned. We started patients on higher dose of rosuvastatin and during their first month or 6 weeks after transplant, so that at baseline, when they came in for their evaluation, the average LDL was 70 in both arms.
Mm.
Now, the AliRocumab did significantly reduce it further so that by 1 year, it was about 35 in that arm, whereas the placebo arm, it didn't change. It remained
Mm.
about 70. So
So, can you
AliRocumab was,
educate me here? I mean, of course, the PCSK, I'm sorry, the statins have been shown to lower CRP, particularly this statin in Dr. Ritker's work, but the PCSK9 inhibitors haven't had as good of a benefit in terms of CRP reductions and anti-inflammatory effects. Is that true?
so we looked at that. It's a great question. CRP actually was stayed the same in both groups from baseline to 1 year. What did change, and actually a little more so in the alirocumab arm, was lipoprotein little a and apolipoprotein B. Both of those were significantly reduced by alirocumab as well.
Really?
Yeah.
Well, I've been on Repatha to try and get mine down, and a lot of people I talk to, it doesn't come down. I think many people will get about a 25% reduction. Maybe three-quarters of people will get a 25% reduction in their Lp(a) with the PCSK9 inhibitor. So that's good to see. Yeah.
Yeah, yeah. Now, the primary endpoint of our study was to look at change in plaque volume from baseline to 1 year based on IVUS analysis. And interestingly, neither group had significant increase in plaque volume. So it numerically increased some, but in our prior studies, we had shown pretty dramatic increases in plaque volume based on IVUS assessment from over the first year. And we didn't see that, meaning both groups did quite well. And so we were unable to demonstrate a significant difference in change in plaque volume between the two groups.
Was there any difference in plaque constituency? Did you see less fatty plaque in the allograft arm?
Yeah, another great question. So we did see that actually, and this probably speaks to the pathophysiology of the cardiac allograft vasculopathy, that neither group really had much lipid plaque at baseline, and it didn't change dramatically in either group. Again, probably just a reflection of we didn't have the power and the ability to demonstrate a difference. As I mentioned, we also looked at coronary physiology. We didn't see significant differences, which is also a little bit different than what we had seen in previous studies. The microvascular function in previous studies had been abnormal at baseline, I think because of some of the response to the transplant, but in our study, it wasn't, and it
Hmm.
remained in the normal range during follow-up. And so we did look at some subgroups, because we were wondering, well, maybe we just had people who are quote unquote too healthy or too well
Right.
controlled lipids. And so we looked at a subgroups, forest plot. And what came out was that older patients, there was a significant interaction. They tended to
Hmm.
do better with alirocumab compared to placebo. Patients who had LDL values above the median level did better, and
Yeah.
patients who had apolipoprotein A above the median level. So those groups there was a significant interaction. And so it makes me wonder if we had followed patients perhaps longer, or B, if we had enrolled a more enriched population where we could focus on the higher risk patients, we might have been able to meet our primary endpoint.
Yeah, I presented a result last year of infusing ApoA1 in post-MI patients. Overall, no statistically significant benefit. It trended. But in those people with an LDL greater than 100 at baseline, there was a dramatic benefit and there was a positive interaction term. So, I think, you always wish, oh, if we just done it in the hyperlipidemic people, but
Yeah,
that's why we do
yeah.
it, right? So maybe we'll do a reload and do another study. But that kind of makes some sense, I guess.
Yeah, so I think we can conclude that PCSK9 inhibitors are safe and effective at lowering LDL. In our study, we did not see a significant difference in development of cardiac allograft vasculopathy, but there were some, I think, issues that may have impaired our ability to show that.
Wow, always a big fan, Bill. You do such great work on all of this. Again, it's the model of how people can do great research without doing mega trials. You know, you get mega data, So great work. Thanks for joining us, Bill, and thanks to all of you for joining us here live from HA 2025.
Thanks, Mike.